Welcome, everybody. This is going to be my journal club. I have done two different articles about two different things that I'm pretty interested in, and my lovely preceptors, Dr. Staples, helped me a lot with a lot of things right now. So we're just going to go right into it then. All right, can you guys see everything? Yes. Okay,
Yep, we can
so
see it.
this is my first article. So it looked at the effect of avoiding cow's milk formula at birth on prevention of asthma or recurrent wheeze among young children by Tachimoto and al. So the background for the study. Many studies have shown that food sensitization in the first 2 years of life is associated with an increased risk of asthma. So the theory behind this was that initially there's a lot of theories that breast milk or breastfeeding itself could help prevent the occurrence of asthma, but there have been many recent studies that have shown that this is not the case. The theory behind breastfeeding helping with the occurrence of asthma is that the human milk oligosaccharides, the secretory immunoglobulins, lactoferrin, and bacterial microbiota from the breast milk can prevent bacterial adhesions as well as provide nutrition to the gut microbiome. When we look at the stool studies of breastfed babies, they tend to have increased numbers of bifidobacterium and lactobacilli in their biome, which helps with a lot of the development of the gut microbiome. If the immature gut microbiome is not initiated on breast milk and solely formula fed, the cow's milk protein may have a chance to not be as digested as well by the gut from the microbiome and cause stimulation of the immune cells within the gut, triggering sensitization episode and possibly increasing the risk of asthma, and which kind of leads to the whole food sensitization factor. And so their design of the study was to see if there any difference in avoiding this cow's milk formula when their gut isn't so formed yet. And so is their question of their study was, is asthma or recurrent wheezing among children affected by exclusive breastfeeding in the first 3 days versus breastfeeding with supplemental elemental formula? And so the design of the study, so it was a randomized clinical trial that was conducted at a university hospital in Japan between October 2013 to January 2020. 312 newborns were randomly assigned into either the breastfeeding with or without elemental formula supplementation or breastfeeding with cow's milk formula supplementation for 5 months. 151 infants for both groups were followed until their second birthday, and if they developed any atopic symptoms such as eczema, allergic rhinitis, any wheezes or any kinds like that, they continued within that study. And there were about 77 children in both groups, 77 in the breastfeeding with or without elemental formula, and 81 in the cow's milk formula group that were continued to be followed. They had some inclusion and exclusion criteria. The inclusion criteria includes newborn infants at risk for atopy. So they selectively chose newborns that came from families that had at least one family member, one close family member that had atopy, such as asthma, eczema, allergic rhinitis, and food allergies. Their exclusion criteria for the study was that any infant that were less than 36 weeks of gestational age, birth weight less than 2,000 grams, serious congenital anomalies, or any abnormal delivery such as asphyxia or low APGAR scores were excluded from the study. And this is just kind of a picture form of how of all the study participants in this, and kind of shows that there was 330 that were available for the study, and then 18 were excluded based on their criteria, and so 312 were randomized into the group with cow's milk formula or without cow's milk formula and supplemented with either elemental formula or just breastfed solely. And they continued until they were about 2 years of age, looked for any atopic symptoms, and then if they had atopic symptoms, they continued to follow up. And this is just kind of a big poster presentation of what they found and kind of shows the population. So there was 152 boys and 160 girls, and looked at the intervention, which we were talking about, the breast milk with elemental or breast milk with cow's milk formula, and we'll talk about the findings later. And so one of my biostatistic teaching point for this article is a risk difference. So what is risk difference? Risk difference and attributable risk are actually the same thing. They're just different names for the same thing, but it is the amount of risk which decreases or increases with the exposure that exists compared to that when the exposure is absent. A positive risk difference indicates that there is an increased risk from developing the condition with the exposure, while negative risk difference meant decreased risk of developing the condition with the exposure. So when I interpret this, this is basically telling me the chance of something happening if I do this. And one of the things that we need to know about attributed risk is you can also use it to determine the number needed to harm, which is 1 over attributable risk. And so this study used the risk difference to kind of show how cow's milk formula or without cow's milk formula affected the development of asthma or wheezing. And so the outcome, they separate the outcome into 4 different things. And we'll start with the first one, the main question for this study, which is the effect of avoiding cow's milk formula at birth on asthma or recurrent wheezes. So in this 330 group, they looked at the median age of diagnosis which was around 2.8 years, and 42 infants in total were diagnosed from the entire sample population. Analysis of the total study showed that there were only 15 of 151 infants in the no cow's milk formula group compared to 27 of 151 infants in the cow's milk formula group. So 9.9% versus 17.9% of the group in the total study population were found to have asthma, which you can see that there's a big difference in the cow's milk formula versus the no cow's milk formula group. And the risk difference for this is about negative 0.079, which shows that it's in the negative direction. And so if you don't expose them to the cow's milk formula early on in life within the first 3 days, you were at 7.9% chance less likely to develop asthma. They also used the extended follow-up subpopulation to figure out the ones that had the atopic condition after 2 years of life, and they followed them until they were 6. And results of the subpopulation study showed that 15 of 77 infants in the no cow's milk formula group were significantly less than the 27 of 81 infants in the cow's milk formula group to develop asthma or recurrent wheezes. So this risk difference was about 13.9%. Different in that the group that did not have the cow's milk formula were less likely to develop asthma. The next one that we looked at in the study was the interaction of vitamin D and avoiding cow's milk formula at birth. So the study talked about 2 different hypotheses with the vitamin D outcome. So there's 2 hypotheses of how vitamin D affects asthma. The vitamin D excess hypothesis states that high levels of vitamin D actually led to increased allergies, while the vitamin D deficiency also can contribute to increased risk for asthma and allergies. One of the interesting things is Dr. Staples actually did a study on the effects of vitamin D on the prevention of asthma in obese patients. So there's a bunch of different studies out there that show different results with vitamin D. And so when they looked at their study, they took vitamin D levels from 5 months old and from 24 months. And these were separated into either higher than the median level or lower than the median level. And so for the age 5 months group, the median level of vitamin D was 29, and for the 24-month group, it was 21. And so at the 5 month of age, in that subgroup with the higher vitamin D level, avoiding cow's milk formula at birth significantly reduced the incidence of asthma with 5 of 78 infants compared to 17 of 69 infants with a risk difference of 0.182. So this means that there was an 18% less chance of developing asthma if you were in the no cow's milk formula group. There was no interaction between vitamin D levels at 24 months of age and the interventions for the risk of asthma. And so the next thing they've looked at was the interactions between total IgE levels and avoiding cow's milk formula at birth. When looking at this data, there was no statistical interactions between total IgE levels at 5 months, as the interventions for most of them did cross the zero, which means that the confidence interval didn't show any significant changes. However, when we looked at the 24 months, they were separated into quartiles because the level of IgE was so vastly different between a lot of the different kids. And so when we looked at that, a lot of these levels weren't really significant unless they were above 50 international units per milliliter. And so there was a significant reduction when avoiding cow's milk formula. 2 of the 38 infants in the no cow's milk formula affected with asthma, while 14 of 32 were affected in the cow's milk formula group. And so discussion from this, so from the study, it was noted that by avoiding cow's milk formula for at least the first 3 of life, the risk of asthma appears to have decreased when compared to the group that was supplemented with elemental formula during the first few days of life. And this kind of goes back to what we talked about in the beginning, which was that the breast milk has some immunoprotective functions to it, as well as helping develop the microbiome of our immature infant gut. And with other studies, they've also seen that there are more human viruses that are in more of an abundant density in the gut for infants that have been supplemented or just solely fed on cow's milk formula. The study also showed that the incident did not differ by the duration of adherence to the cow's milk formula versus the just breastfeeding. And so basically said that it doesn't really show a difference in how long they stayed on this. It was just that the first 3 days of life may be an important period of time for the intervention to occur. And so strengths of limitation of the study include that this study was a randomized study that tried to remove as many biases as possible. It also looked at multiple variables that we know now to have been associated with increased allergies or increased ATP, such as IgE levels, vitamin D levels, and they actually looked at a specific IgE level, but didn't really see too much from that. And the duration of the study in that they followed individuals from when they presented with ATP symptoms. And so it looked even further than just the 2 years that for some of them. But some of the limitations from the study include this was actually a study that looked at food allergies first, and they used the same data from that to extrapolate some other stuff to find the article that we're talking about today. Another limitation is that they separated these individuals. They found individuals that were already at a higher risk of developing ATP rather than having a group where they had no real good family history of ATP and comparing that to a group with a stronger family history of ATP. The sample size of the study is a little bit smaller for really detecting any significant differences. And when you looked at the risk difference for a lot of our studies, they weren't really significantly big enough to where you say that we might change your clinical practice or anything like that. And one of the things from the study is they've only done the study in Japan, so that doesn't really account for some of the environmental changes, the socioeconomic changes, and the geographic changes that we can see, which can have some impact on the development of asthma. When they looked at so many subgroups and now analyzed some of these subgroups, these can lead to increased type 1 errors, and studies did not investigate other factors that make asthma a burdensome disease, such as they didn't have any inclusion of any data about how many more hospital visits they had, any ED visits, or any doctor's visits during all of this. And lastly, one of the things that about the study is since they is supplemented with either elemental formula or just cow's milk formula, one of the things is a lot of our population can't really afford elemental formula, because I know at least one of the cans of Neocate is pretty much like $100 a can. And so the feasibility of supplementing with elemental formula for an extended period of time is going to be pretty hefty of a burdensome to the family. So for me, I think this study helps open my eyes to some things, in that if I know that there's a family that has an increased risk of ATP, I would I would think about maybe supplementing with elemental formula, but at the same time, I know the risks of elemental formula and with the burden of elemental formula, we have to kind of weigh all of those together before we make any conclusive judgment on during clinical practice. And I would like to see the study replicated in different places before I would say that this is a stronger recommendation for a lot of our families. And during the first 3 days of life, usually we try our best to really push breastfeeding as pediatricians because we know the benefits of breastfeeding and how many things you can get from breastfeeding. So I feel like even with that and said, we have a lot of time that we already just push breastfeeding on these infants. So that first 3 days of life, we think we're mostly breastfeeding at that point, anyways. So that's the end of the first study. Does anybody have any questions?
Hey Mason, this is Scott.
Hey, Scott.
I have a general comment. I think you make a good point about kind of like the generalizability of the area in Japan than for like our population, just because I always remembered like in medical school, we had learned about how certain like gastric and esophageal cancers are a lot more prevalent in Japan. And I think that'd be interesting, you know, if you're talking about how the like link between cow's milk formula and breastfeeding and asthma somehow has to do with, you know, at least in some part to like the microbiome, and how that might be affected. It's kind of interesting. I wonder if there's something there that would make whatever that reaction is different in those populations, based, you know, compared to ours, and if it has any relation to why there's higher rates of cancer, like GI cancers in those populations than there are in ours as well. And so making that link, it would be interesting to see if they do more study to see if there are protective factors that we have or they have that make that link between, you know, GI absorption of milk and asthma any different. So that was a good point.
And I think there's a lot of different cultural things that are in play with all of this too. Oh, there's a lot of stuff that could be studied between different cultures and how they practice childcare and all of that, and how they basically manage a lot of the stuff. So I think there's a lot of interesting things out there to kind of investigate with that.
Hey Mason, it's Dr. Carney. I just was going to make one quick comment. I think this is actually a really cool study that shows some good correlation, right? Because that's what they're trying to show. They're trying to show correlation, not causation, with this stuff. And the thing that you actually recognize as a limitation of using only those with a strong family history of ATP, I think that's actually a positive benefit for this study, because that's really the patient population that they want to focus in on. They don't want to make this generalizable to everybody. They want to say, hey, if you have a strong family history of atopy, this is just another thing that you might want to consider when you're making your choices to decrease your risk of developing significant asthma. So I think that was actually one of the benefits of the study, is it keys in on a specific population that you can focus in on a little bit more than just the general population, which is, I know, what we always want to try to do. But at the same point in time, it can be helpful when you know walking into the room that, hey, this family has a significant history of things. I thought that was pretty cool. And just like Scott was saying, just like you were saying, all the factors that play into the development of atopy and asthma, the hygiene hypothesis, everything else that goes along with it, in addition to the geographic environmental factors you guys are talking about, are a big deal. So really good job. But I thought this was actually a really cool study.
Yeah. All right. So it definitely, I think one of the things that the study does talk about the most is just like making sure we key in on things we looked at. So exactly like what you said. And so I think that does change a little bit of how I see more of my atopic patients. But I think more and more studies need to be done before I really tell people, hey, we should probably supplement with elemental formula before that. So I think this was a pretty interesting article, and that's why I chose it. And my next article we looked at was the high flow nasal cannula and bronchiolitis patients at a pediatric emergency department, and looked at the trends and outcomes by Lipshaw et al. So bronchiolitis is one of the most common causes of pediatric ED visits and admission for children under 2 years of age. There are many varieties of interventions that have been used to help with the disease process, but none have been high quality other than supportive care, and none of them have been found to decrease admission times or duration of illness with bronchiolitis. One of these interventions included the use of non-invasive positive pressure ventilations, such as high-flow nasal cannula, which we call Vapotherm here, which have shown any differing results other than helping with some of the heart rate issues and respiratory rates. And even in studies with that, there are mixed results in how efficient it is at improving heart rates and respiratory rates. And there are potential downsides on increasing the use of high flow nasal cannula, which include a cost and interrupted oral feeds, which a lot of more recent data have shown that oral feeding has been associated with decrease in admission time. And so from their study, they wanted to determine the clinical factors associated with the use of high flow nasal cannula in the emergency department on young children with bronchiolitis. And they wanted to see if there was an increase in the use of it, just based on what the hospital did, and to describe the trends of high flow nasal cannula use and associated clinical important outcomes over the 6 consecutive years. And so before I start talking about the data, I wanted to talk about what they used to kind of help show what they saw in their data. So when they got all of their data, and after all the statistical analysis that I don't quite really understand just yet, they used that to calculate the interpreted time series, which is an analysis that is a valuable study designed for evaluating the effectiveness of population level health interventions that have been implemented at a clearly defined point in time, and which in this case is the intervention of using high flow nasal cannula and the hospital policy changes in how they use high flow nasal cannula, which I'll talk about in a little bit. It is used to help establish trends after the interventions are implemented, and it can pictographically display how these changes have caused any increase, decrease, or any basically no change in how and whatever variable they measure. Many factors need to be accounted for when you're doing interrupted time series, which includes seasonality, which is a big factor in when we see bronchiolitis patients. We have to kind of account for provider variability in their practice and how they manage bronchiolitis and clinical covariations, including some other important things such as asthma, which can also exacerbate some bronchiolitis babies, or if they have underlying symptoms of asthma and things like that. And so the design of the study, it was a single study, retrospective cohort study of all children presenting to a tertiary care children's hospital ED. Time frame of the study was between January 1st, 2013 to June 30th, 2019. At the beginning of the study, high flow nasal cannula was only allowed in the ED and the PICU, and gradually during this time period, high flow nasal cannula was allowed on the inpatient floor. After 2016, the hospital actually allowed the high flow nasal cannula to be used on the floor. And then after 2018, they actually allowed they liberalized the use of high flow nasal cannula to allow for 2 liters per kilogram. No clinical guidelines for the initiation of high flow nasal cannula was established in the ED during the study. And they actually limited the participants in the group to between the ages of 2 months to 24 months, and excluded anybody of less than 2 months on a high flow nasal cannula, just because there was concerns that there was apnea that caused the use of high flow nasal cannula. And I didn't include it in the slides, but they basically had to look back through all the charts and looked for the ICD-10 codes that actually correlated with the diagnosis of bronchiolitis to see if they used high flow nasal cannula or not at that time. And so from their data, when they looked back, they looked at these clinical variables such as age, the sex of the patient, encounter dates and time to look at when in the seasons they were coming in with bronchiolitis, their medical history, if they were evaluated in the resuscitation bay, their emergency severity index triage score, which I had to actually look up. And it's basically that number that we used to see on our tracking shelf that kind of determined how sick they looked when they presented to the triage station. They looked at the vitals, they looked at the oxygen saturation, and for their study, they looked to see, they said that anything less than 90% was to be hypoxic. Their medications, initiation of high flow nasal cannula in the ED, and their disposition. This is just a picture form of how they conducted the studies. And so there were 87,357 total eligible encounters with 11,660 encounters with the ICD-10 code for bronchiolitis. 511 of these were excluded because of complex medical conditions that could have confounded how they used the high flow nasal cannula. Of the 11,149, 6,6430 were discharged and 4,719 were admitted, and 902 of these patients were initiated on high flow nasal cannula in the ED. So the median age of admission was around 8.4 months, with 59.5% being males and 40.5% being female. Okay. So the outcomes of the study. So they saw that children started on high flow nasal cannula were older, a bit more likely to be evaluated in the resuscitation bay, had a lower triage score. So lower triage score means they're more acutely ill when they initially present, and concerning vital signs such as low O2 saturations. ED high flow nasal cannula initiation rate among all eligible encounters rose from 1.3% in the 2012 to 2013 academic year to 17% in the 2018 to 2019 academic year. The rate of initiation of high flow nasal cannula on admitted patient increased from 3.3% in 2012 to 2013 to 35.6% in 2018 and 2019. The total admission rate increased from 39.1% to 47.7%. Among the admitted patients, the rate of patients submitted to the PICU increased from 9.8% to 23.2%, and the rate of transfer to the PICU increased from 3.1% to 5.1%. So there's a bunch of different percentages here, and when you cursorily look at the data, it kind of looks like things were all increasing, and after statistical analysis they saw some other stuff. And so when we look at what the clinical variables that were significant on how they were going to be initiated on high flow nasal cannula, it was shown that age, resuscitation at the bay, or being evaluated in the resuscitation bay, their emergency severity index for the triage score, their respiratory rate, their pulse rate, their mean MAP, their triage O2 saturation, if they had any triage hypoxia less than 90%, and their lowest ED O2 saturations were all significant in determining if they were going to need high flow nasal cannula in the ED department. And so when we look at the trends, we are currently looking at their primary outcome. And so they wanted to see what the primary outcome of the initiation rate in the ED were. So in the adjusted ITS analysis, ED high flow nasal cannula initiation increased significantly in January 2016 when high flow nasal cannula was allowed on the general inpatient floor. And so we can look at the trend here, and especially so where the dotted lines are when the changes in the floor policies were. So this first one was when they allowed high flow nasal cannula on the floor, and the second one is where they liberalized the use of high flow nasal cannula on the floor. And just looking at this, this is why I like the interrupted time series a lot, is that it helps me kind of see just throughout the years of how big of an increase everything has been with the initiation of high flow nasal cannula in the ED. And looking at the secondary outcomes, they wanted to see how initiation of high flow nasal cannula affected admissions. And looking at this, after kind of doing some statistical analysis on all of this, it kind of shows that even though that there were increases in the number of admissions, there wasn't a really significant change in how initiation of high flow nasal cannula affected admission rates. So it didn't increase it, decrease it, it really just stayed the same. And there was no real significance in how much they changed their policies on high flow nasal cannula when you look at the different interventions over here on the side. The same thing can be said on PICU admissions. When we look at the ITS, we really don't see any changes in increase or decrease of patients from being started on high flow nasal cannula in the ED to if they need PICU admissions. And lastly, one more. So one of the other things I looked at was transfer to the PICU from the floor. And this also didn't show many changes even with liberalization of their high flow nasal cannula guidelines. However, one of the things that they did note was intubations. And so initiation of high flow nasal cannula in the ED did show that there was going to be some increase in the number of intubations, especially during the second intervention, which was when they liberalized the use of high flow nasal cannula on the floor. And so strengths and limitation of the study. So the strength of the study was just the duration of the retrospective study, the population size of the study, which they were able to extrapolate data from, and the analysis that included different variables to account for, analyze, such as seasonality and all the other factors that we have described so far. One of the limitations, and I'll always bring this up, is the geographic location for a lot of the respiratory symptoms. A lot of times we have geographical limitations that can exacerbate or help with some of the conditions that we see. Retrospective nature of the study could not control the variables as well either. So one of the things that we looked at was just, whenever we have a patient that's in respiratory distress, sometimes we get more vitals and sometimes we get just a little bit of vitals. So really not having as much control on how often we get vitals can skew some of the results that they've seen. And sometimes if they do get admitted to PICU, they'll get more vitals regardless of where they are. So that could help skew some of the results that they've seen. Studies did not mention if there were any other interventions that were used during the study, such as we do a lot of nasal suction here, a lot of hypertonic saline to help with some of the secretions. Other places might do some albuterol or steroids, which we know really won't help the cause, but it would have been nice to kind of see if there were any of these interventions done during the study to see if there was any changes with it. One of the other limitations with this was that the ED did not have any set guidelines for the initiation of a high flow nasal cannula. So there could be a variability of how practitioners down in the EDs practice. And the study did not include any patient under 2 months of age, so we cannot generalize the information to infants less than 2, and especially if they come in presenting with a lot of respiratory symptoms. So discussion of the study. In this study, there was a significant increase in the use of high flow nasal cannula that had an association with allowing high flow nasal cannula on the general floor. However, the initiation of high flow nasal cannula did not change overall rates of admission, PICU admission, or PICU transfer. However, there was an increased rate of intubation over the study period after adjusting for age, the ESI level, the triage ED, lowest O2 saturation. High flow nasal cannula has been shown by some studies to help with tachypnea, work of breathing, and heart rate, but looking at the study, it does not look like it has decreased treatment time or duration of disease for bronchiolitis. From this study and other studies with floor policy changes to allow high flow nasal cannula, this will allow the ED physician's threshold to lower a little bit for initiation of high flow nasal cannula, which could decrease initiation decreases, which could explain the increased usage of high flow nasal cannula. Although there were more admissions on high flow nasal cannula throughout the years, when adjusted for all of these variables, these results were not significant. This likely indicates that high flow nasal cannula cannot be seen as a tool to help with outcomes, but to help more with certain situations such as respiratory distress. One of the important findings of the study was that initiation of high flow nasal cannula does not increase the numbers of transfers to the PICU, which is important which is important in the hospital associated costs.
Yes. I didn't need the later date. I think when it
Dr. Blackburn, you need to mute. Dr. Blackburn, you need to mute.
I did not need the later date. If we can cancel that somehow.
All right. So, however, the study did show that initiation of high flow nasal cannula did lead to more intubations. It's important to figure out if this is because of the disease severity or if this was more because the threshold was lowered because the patient was failing high flow nasal cannula. This also showed that high flow nasal cannula does not have any benefits in decreasing the length of admission or the disease process itself. Use of high flow nasal cannula must be judicious and stepwise to prevent unnecessary lowering of thresholds when deciding to increase in respiratory modalities. Guidelines for initiation should be created to ensure proper and safe use of high flow nasal cannula to prevent unnecessary escalation of care. So in terms of my clinical practice, high flow nasal cannula can be seen in two different ways when I looked at this study. It can be seen that it's not something to help with keeping patients out of the hospital. That's the first thing I got out of the study. But it's also it's helped me realize that high flow nasal cannula, there comes with benefits and risks, and we have to kind of understand why we're doing this to make sure that we're providing the best care for the patient rather than slapping a high flow nasal cannula on just because they're having some increased work of breathing. We should work in a stepwise approach to do a lot of the supportive care first before we think about high flow nasal cannula. And so because this, even with the initiation of high flow nasal cannula, this doesn't decrease any admission times or any transfers or escalation of care. And so we just have to look at the severity of the disease process in the individual patient before we make any clinical judgment calls. All right, any questions?
So I was going to comment really quickly on this. Something that I thought would have been a useful piece of information is if they had also looked at other interventions during the admission time, like comparing frequency of suctioning that was required. They also didn't comment on whether or not they allowed PO feeding on high flow nasal cannula, which varies between institutions. There's a lot of other things that are a part of these bronchiolitis admissions that can contribute to morbidity and not just the cost of the admission as well, that none of that was commented on. And also you have to wonder, if you look closely, this study was done at Cincinnati Children's, which is a really large hospital with a lot of fellows. And you wonder if, over time, if some of these are homegrown fellows from their residency program, that as they finished and they were fellows in the ER, like, was there kind of a snowball effect of their comfort with high flow nasal cannula, not just because they knew they weren't going to have to go to the PICU if they were on high flow, but was there some confounding with just internal comfort with that modality that led to some of these increased rates as well. I don't know, it's an interesting study. Let other people comment.
Yeah, I would agree with Dr. Staples' points. Mason, I agree totally with your points. I think the geography is an element there, whereas if you look at areas of higher altitudes and then you're trying to transfer these kind of data to perhaps a Salt Lake City or Denver, there may be issues with bronchiolitis in that regard regarding the pulse oxes, et cetera. I think what this study does do, it shows you the importance of a retrospective study. Many times we look at prospective studies being the top of the evidence-based medicine ladder, but this value of the retrospective study, because what they did was look at data from a prospective study on an inpatient perhaps, and look at the value of HFNC. And then of course, like Dr. Staples said, they kind of just got into that routine and transported it down to the outpatient or the emergency room. And you can't necessarily do that. And this kind of retrospective study is not trying to say necessarily that it's bad, but it's just trying to say you don't have the data of which you presented that shows the effect necessarily relative to just because it works on the inpatient or it's used on the inpatient, therefore we use it on the outpatient. And so the retrospective study does that. And when the dust settles, it's, if nothing else, it's a healthcare value point. It's, are you using it? And it's going to be a cost. And so therefore you do it just because it has been done on the inpatient. And that's not necessarily so. So I do think it's, again, shows you to some degree the value of a retrospective study.
I have a question. Maybe Dr. Staples, this is a good one for you. Do you think that this is just like these kids maybe are getting put on high flow because they have the option and there's no reason not to on day 2 of their disease process. And when we're here, we usually try to fight through that, and we don't get to high flow until it's day 4 and they're really decompensating. And like, it doesn't really matter how much support you give them on day 2 of bronchiolitis, day 4 is still going to be the worst. Whereas, I don't know.
So I would speculate that their use of high flow nasal cannula early in the ED probably is due to the fact that high flow does not mean a PICU admission. So if they're already thinking these kids are probably going to be admitted for their bronchiolitis, the use of high flow is not going to impact their level of care. So I think that probably impacts their decision to use it in the ER. And then I'm trying to remember the second part of your question.
Like, do you think that, yeah, I think it's so easy to start it, which is why it probably gets started earlier. And do you think like part of the thing is that it doesn't really matter if you start high flow on day 2, you're not gonna completely fix bronchiolitis because we know that like day 4 is kind of when it gets the worst. So it's still gonna progress whether or not you're on high flow.
Well, and this study kind of suggested that if you're gonna end up intubated, the high flow didn't seem to impact whether or not you ended up at intubation.
Yeah, and then just going off Dr. Stoller's point, it's so like when we do high flow, we basically say like we wash them for at least 4 days, like you said, and then we escalated care. And then just looking at the study itself, when you look at it retrospectively, they were basically on high flow and it didn't decrease anything regardless of when you started. And they started this just right when they got to the ED. So when you think about starting it early versus later, it didn't show any difference in it. It's really just about understanding where your patient's respiratory work of respiratory breathing is, and then kind of deciding what's best for the patient. So I think just with what Dr. Stoller said, it's a retrospective study to let us know that, you know, just because we can do it doesn't mean it's going to have a benefit to it.
All right, any
All right.
other questions or comments before we wrap up? All right, thank you guys so much for your time. I hope you have a good day.
Thank you. These are my sources. Okay, stop sharing. Bye, everybody. All right.